Hello and welcome to the EduTalk series hosted by Biotone EduPartner School Program, and massage industry experts. With the continued interest and popularity of the EduTalk series, Biotone continues to support virtual learning and building massage community by connecting you with industry experts who share their knowledge and expertise on topics not only for class discussion, but career success. Tonight's expert is Brian Trzaskos, President of New Health Incorporated and Director of Education at the Somatic Coaching Academy in upstate New York. He's a holistic health expert and co-creator of sensation-based motivation coaching. Brian's nationally recognized for coaching, training, and mentoring healthcare professionals in evidence-based practices of mindfulness, Tai Chi, and trauma-sensitive somatic coaching. Let's listen and learn as Brian discusses trauma-informed practice, an evidence-based approach to inclusive, compassionate, and holistic care, looking at trauma-body connections and how to make your practice successfully trauma-informed. Experts estimate 90% of people have experienced trauma at least once in their lives, and post-traumatic symptoms can hide as common maladies, including chronic pain, headaches, depression, and anxiety, along with related issues people seek massage therapy for. Thank you, everyone, again. Be sure your video is off and sound muted. And Brian, thank you. I know we have a lot to get to. Looking forward to hearing your presentation. I'll let you take over and see you on the other side for chats. Okay, it's all yours.
Thanks so much, Danelle. Really appreciate the invitation to be here tonight. I'm so grateful. You know, we met a little over, I think, a year ago at the national conference, and I've just since then I've been really appreciative to have the connection with you, and have been asked to be here tonight. So thank you so much, everybody. I'm just going to pop into the screen share. Hopefully this will connect and people will be able to see this okay. Can I just get a confirmation on?
All good.
All good, then all great, perfect. All right, everybody. So I'm just really grateful for Biotone also for putting on these talks. One of the things that Donnell and I talked about in getting ready for tonight was the importance of education and continuing to learn and continuing to bring the most recent evidence into the world of massage and body work and helping people make really important transformations in their lives. So I think this is a super important topic, but also the EduTalk series is really amazing. And I'm really excited that Biotone's offering this for the community. So this is really fantastic. So thanks so much for you for being here. Thanks so much, Donnell, for hosting. And thanks so much, Biotone, for supporting the work that we're doing here. Okay, so as we jump into our topic tonight, this talk that we're doing is actually a version of a much longer training that I do at conferences and in some of our certification programs. I really wanted to try to hone it in tonight, specifically for the time that we had together, to make it hopefully the most practical, useful, and empowering material that you can get in the next hour as we're here together tonight. So as we start our journey, I would like to tell you a little bit about how my journey started in trauma-sensitive and trauma-informed care. About 12 years ago, maybe a little bit longer than that, I was, so I'm a physical therapist by training. I'm also a massage therapist and body worker, have a lot of training and knowledge around, helping people manually work with their bodies, whether it's through soft tissue care, whether it's through myofascial release, trigger point, deep tissue, also lots of kind of manipulative practices that we do, joint manipulation, those types of things. But about 12 years ago, I was working with a client who came in to see me, and she was experiencing back pain. And this client, Shelly, was a friend of mine, actually. I knew her, I thought I knew her fairly well. or I did know her fairly well, but there's always things you don't really know about your friends and the people that you associate with. But she had been a client of mine for some time, and she was having some back pain. I hadn't seen her for a little while. She came back in, some back pain. So we started doing some deep tissue work in her spine, as you might do with someone who's experiencing back pain. And as we were doing a little bit of work, I could tell that she was starting to get a little unsettled on the table. There were some emotions kind of bubbling up for her, some crying and those types of things, which again aren't unusual in a body working session. Lots of times, I checked in with her, and she wanted to go a little bit further with the work, so we kept kind of working. And she kept getting a little bit more unsettled, a little more unsettled, and before I knew it, Shelley was in a state of what I now know is autonomic nervous system dysregulation. She was very emotional. Her emotions really became uncontrollable to a large degree. And not only that, where her emotions were just really running away, but she also became very disoriented, very dysregulated, actually dissociative. She started to not realize or understand where she was or what time it was, what she was doing there. And it rapidly kind of went very quickly into a domain that I was completely unprepared for. And without knowing what to do, I simply tried to hold space for her. But that space holding went from being an hour-long session into 2 hours of holding space and trying to help her get regulated. And that went into 3 hours of trying to hold space and help her get regulated. She wasn't able to stand up, wasn't able to sit up. And I had other patients in the waiting room who were coming and waiting for me to come meet them, but I didn't feel it was safe to leave the treatment room. So those patients were coming and then I didn't show up, so they'd left, and I'm getting messages, where were you? All these kinds of things are happening until I could help her stabilize enough to help her get to the car. And I drove her to her house, made sure she was stabilized, with a neighbor who was able to help her, and then helped her reach out to her physician and those sorts of things afterwards. But what I was left with from that experience is that I never, ever, ever wanted that ever to happen again to a client of mine that I was working with, that was completely over my head, and understanding what could I have done to not have that happen, or be more supportive if that did happen. And this was my kind of launching into a better understanding of trauma-informed and trauma-sensitive care. And I have to thank Shelley a lot for this. She actually was my guide kind of going along after that session to really help understand what had happened in her experience and in her history, and what kind of led her to having that experience in the treatment room that day. And then also helping me to find really good training programs and mentors to help understand how to create trauma-sensitive and trauma-informed programs, again, so that would never happen again for folks. One of the things that I really came to understand, and all of you are body workers here. You're all massage therapists, manual workers of some sort. And so it's likely no surprise to you that emotions and the body have something to do with one another. And as you're working with people in a very kind of intimate way, you're working in people's physical and energetic fields when we're doing body work with people, that not only do emotions get stirred up, but really a person's history can get stirred up in a lot of ways. And as we talk a little bit more today about trauma and trauma history and the massive prevalence of it, it's no surprise that oftentimes the things that do come up in sessions are directly related to past trauma, and that people's nervous systems can quickly sometimes move into a state that is not manageable for us as professionals, and also not super productive for the client in the long run. So hopefully we're going to help to address some of these things today, and leave our talk today with a better understanding of what can we start to do to help people and ourselves meet trauma in new and more productive ways. So let's first start off by defining trauma. If you look in the news and you look on social media and those types of things, that word trauma does get used quite often in lots of different ways. And I've read a lot of articles how there's some pushback on, oh, is everything trauma and which trauma? This is trauma. Everyone's saying that's trauma. And so this is the way I kind of like to look at it. I like to kind of look at it through the lens of the nervous system, which we'll talk a little bit more about. Let's just define trauma from the Substance Abuse and Mental Health Services Administration. So they define trauma as an event, series of events or set of circumstances that is experienced by an individual as physically or emotionally harmful or life-threatening. So I just want to put a pause in it right there. And let's look at the first half of that definition for a moment. So it's an event, series of events, or set of circumstance that is experienced by an individual as physically or emotionally harmful. So when I read the first half of this definition, what jumps out at me is the practice to really step back and not judge what someone else experienced as traumatic, because we all have different perceptions as we go through life, right? We all have different perceptual filters, we all have different histories, we all have different belief mechanisms, all those kinds of things. And two people will not likely always experience the same event as traumatizing to their nervous system. So if an individual experiences something as physically or emotionally harmful or life-threatening, then who's to say, who am I to say that that wasn't life-threatening for them? So we can see that trauma can be very individual for people. Now, with that said, let's also recognize that trauma can certainly be collective. Trauma can certainly be generational. So it can expand obviously beyond the individual. But as far as this definition is concerned, what I'd like us to walk away with and say, wow, you know, none of us has a right to determine what's traumatic for somebody else. That's what jumps out at me in that first part of that sentence. Now, the second part is that, and that has lasting adverse effects on the individual's functioning and mental, physical, social, emotional, and spiritual well-being. So what that tells me is trauma doesn't locate itself only in a physical issue. It doesn't only manifest in a mental or a mental emotional way. Trauma is holistic in our whole experience. So when someone has experienced trauma and their nervous system is traumatized, all of them is traumatized. Their personal life, their relational life, their social life, their environmental life, it kind of ripples out into all these different planes. So we want to recognize, again, just from this definition, that trauma is very individualized to a person's own perceptual experiences that's determined whether or not it was life-threatening or harmful, and that it has lasting effects in the person's whole life in kind of a broad context. That's the way I like to kind of break down this definition of trauma from the Substance Abuse and Mental Health Services Administration. So let's look at trauma prevalence here for a moment. We're going to start over here on this side of the scale and look at stress. Now, stress, everyone experiences stress. 100% of humans experience stress. Let's just circle that 100% right here. So 100% of everybody experiences stress, and stress is adaptive. Stress is important. We know that if a human being cannot experience stress, they actually don't live very robust lives. We know that stress is really important for neural development in a lot of ways. So stress isn't necessarily a bad thing, but we all experience stress. Now, in normal situations, let's think about a normal stressor. Let's say in the morning you're running late for work, and you look at your watch and you're like, oh my God, I'm late. I have no idea how I'm going to make it to work on time. And so as soon as we have a perception that we're going to be late and we're like, God, I need a little help, your body goes, okay, I'll give you some help. And it gives you a little shot of adrenaline, cortisol, heart rate goes up, blood pressure increases, all those things start happening to help you get out the door and help you get to work on time. It speeds us up, right? Helps us put the foot on the gas and get out the door and on time. Now, so let's say it works. Let's say that stress bump that we got gets us to work on time. Hey, we get to work on time. What happens? There's no more threat. Our body then returns to normal. so that we had a stress response, an uptick in our metabolism. It worked. It was successful in getting us what we needed to get. Our nervous system goes back to normal. That's a healthy and normal stress response, okay? So when everybody experiences those kinds of things on a kind of a regular basis, I would guess some people more than others, but we all hopefully have that adaptive response that helps us to live a full and rich life. Okay, now what is a traumatic stress? So what the research tells us is 90% of us, and these numbers were before COVID, by the way, before the pandemic. So, I mean, I haven't seen any numbers after that, but in all likelihood, like the numbers probably climbed a little bit under, like just looking at the data around burnout and those types of things that are happening since COVID. We can kind of extrapolate the idea that probably more of us experienced traumatic stress after COVID than before COVID, but let's just say 90%. So 9 out of 10 of us experienced traumatic stress. So what's traumatic stress? Traumatic stress is a stress response that's directly linked to a traumatic experience. So let's say that you are running late for work in the morning. You're like, oh my God, I'm late. You get a little bit of a stress bump, you get in your car, you drive to work, and you get in a car accident on the way to work. Now, when you get in the car accident, you have an even bigger stress response, right? Your heart's racing, your blood's pumping. Thank God you're not hurt. The car's hurt, but you're not hurt. No one else is hurt. But you really went into a massive kind of a stress overload from being in the car accident. Now, let's assume you're in a car accident, but you're not hurt, and you call up your friend, your partner, your neighbor, your parents, and you're like, oh my God, just got in a car accident. Oh my God. And you kind of talk it out and you talk it through, you realize it's going to be okay. And then your nervous system goes back to normal again. That's a normal traumatic stress response. Okay, so you have a stress response, goes back to normal. That's normal and healthy. So 90% of us have stress responses that are specifically related to traumatic experiences. Those are experiences that have to do where we perceive physical, emotional harm or life threat. Okay, again, these are perceptions, and none of us has any right to judge anyone else's perceptions. So 90% of us have that. Now let's jump all the way down to the other end of the spectrum for a second. Now, between 20% and 3.5% of people who experience a traumatic stressor go on to develop what we call post-traumatic stress disorder. So post-traumatic stress disorder, which I'm sure most of you have heard of, if not all of you have heard of before, PTSD. There are like 6 different check boxes that would give someone a clinical diagnosis of PTSD. There are things like, marked and prolonged emotional distress, dissociation, re-experiencing. There's a bunch of check marks down there where someone can say, oh my God, you're diagnosed with PTSD, which allows you then to receive certain services and have kind of certain care on those types of things. Now, what this means, though, if you look at these numbers, what I think about a lot are the people that are lost in the middle here. That means 70% of people that experience traumatic stress have what we call post-traumatic stress syndromes that do not amount to the diagnosis of PTSD. So how does this occur? So let's imagine you're in a car accident and you have a stress response, heart rate goes up, blood pressure goes up, muscle tension increases, all those things happen, and your nervous system does not go back to normal again. It remains either elevated or what we call dysregulated, which we're going to talk a little bit more about. So it does not return to normal. It's somehow out of a normal spectrum of function. That's what we call post-traumatic stress. And post-traumatic stress can show up, again, in all kinds of ways. It can go up with re-experiencing. It can show up with spotty bits of dissociation, but it can also show up as emotional dysregulation. It can show up as all these subtle signs of difficulty with memory, difficulty with concentration, difficulty staying present in conversations that feel threatening. All those things are results of post-traumatic stress. So there's a lot of people walking around, I'll raise my hand being one of them before I realized that this is what's going on. Listen, I just thought I was broken. I just thought I was broken and ineffective and, need I say stupid in a lot of ways and or just too emotional, those sorts of things. So a lot of us are walking around believing those things, where the fact is, might they simply be linked back to previous experiences of traumatic stress that have simply never resolved themselves and continue to live in our nervous systems for days, weeks, years, months, even decades afterwards, because we've never known that there is something we can either do about it or had done something about it to help balance those systems out. And these people experience a lot of, as we're going to find out, well, muscle tension, pain, and they're seeking massage therapy services without realizing that the underlying cause potentially of what they're experiencing has to do with post-traumatic stress, simply because they don't meet all of the check marks for post-traumatic stress disorder. So, please, pop any questions in the chat. Again, we're going to answer these afterwards. But just pop them in there. Happy to have a conversation. A lot of people, a lot of questions around this. I think it's really important to address. Okay, so let's keep going. All right, so let's dig a little deeper in here. If you have not, or have ever heard about the ACEs study before, the Adverse Childhood Experiences studies, I urge you to go to acestoohigh.com and get a little more information about them. But I'm going to give you kind of just a quick overview right here. So back in the 90s, Kaiser Permanente and the CDC did a collaborative study of 14,000 people. And this research has been done again and again and again and again and again. But this was a watershed study that really launched off a whole different understanding of childhood experiences that are associated as traumatic and the way that they are experienced for long periods of time in our nervous system afterwards. But so 14,000 participants in the Bay Area, San Francisco Bay Area, were given physical exams, confidential surveys, family dysfunction, current behavior, it's all kind of right there. And the results showed overwhelmingly that evidence of childhood trauma related directly to multiple chronic health conditions, adult psychiatric disorders, and at-risk behaviors. And what we do want to say too, just the demographics of the study, where the average age was 59 years old, and 75% of the people in the study were white and college-educated professionals, which lets us know that we'll kind of, number one, we just want to absolutely say at-risk populations are at a much higher rate and risk of traumatic experiences. Let's just kind of say that right away. And what we also want to say is that trauma itself affects the nervous system of all humans, actually all mammals, in a very, very similar way. It goes beyond our belief systems a lot of times, our race, our gender, all those sorts of things. While at the same time, yes, absolutely, at-risk communities, marginalized communities, experience much more trauma than more affluent and well-fed communities, let's put it that way. But this is the research I do want to share with you, gang. It's, if someone scored on this ACEs exam, and if you just hearing about this now, I urge you to go to acestoohigh.com and take the ACEs exam for yourself. When I took it for me, I was like, wow, I did not realize that my childhood experience could be considered in the way that the findings kind of came out to be considered. But these numbers are kind of, we're sorted out of this, that if someone had more than 4 adverse childhood experiences in their history, check this out, folks, it increased their risk of chronic pulmonary disease by 390%, chronic pain by 300%, hepatitis by 240%, stroke by 240%, depression by 460%, attempted suicides by 1,200%, asthma 87%, cardiovascular disease 220%, and diabetes 160%. So these are the people that are seeking out your services as massage therapists and body workers. How many of you work with people with chronic pain? I mean, like, everybody's probably raising their hand right now, right? How many people work with folks with chronic pulmonary disease, or have experienced a stroke, or are depressed? I know anxiety is not on here too. there's numbers like this research is being done again and again. I think that's a pretty strong link. So what the numbers reveal is that people who are traumatized are not like simply always hiding in their rooms and afraid to go out of the house. They are seeking services. They're trying to help themselves. They are in your offices, they are in your clinics, and you are working with them and with their bodies. And again, just from the understanding that as massage therapists, we know we are working in people's, not only their soft tissue, not only their connective tissue, we're working in people's energy fields that are associated with their soft tissue, their connective tissue, of course. And all of our history lives in our nervous system. And so we are frontline, folks, frontline to both be very, very helpful for people who've experienced past trauma, and at the same time, need to be better informed about how to really help people and help keep them safe. And that's one of the things I've really come to learn over time. All right, so how exactly does this kind of work? Now, again, I've tried to simplify this down for our time together tonight, because in our longer trainings, we go very deep into this, very deep into understanding like how trauma specifically affects the nervous system. But let's look at it like this. Let's say a individual has a regulated autonomic nervous system. Our parasympathetic, sympathetic nervous systems, fight and flight, rest and digest, they work well together. During the day, we're a little more active. At night, we're resting well. Let's say that's happening all well. And then we experience some type of threat. Let's say the threat, again, comes in the way of a car accident. The threat could be in the way of some type of adverse interpersonal engagement. This threat could certainly come at an adverse childhood experience at an earlier age. And again, if you take the ACEs, you'll see what are considered adverse childhood experiences. And you'll understand, hey, where do you rank on that spectrum? ACEs is actually a survey I do give my clients at times if I have a suspicion that they are a high risk for experiencing or have experienced trauma, because I want to be able to understand and support them going forward. So someone's experience is a threat. Now, all mammals, our first line of defense, we call these the 3 levels of safety. The first level of safety for all mammals is what we call the social engagement system. And this has to do with actually the vagus nerve, the ventral vagal complex. If you're a parent, you've likely at some point in time been in the kitchen cooking or doing dishes or maybe doing your book work or your taxes, and you hear your kids playing in another room. And then all of a sudden you hear one of your kids will just change their tone of voice a little bit, and you'll go, what is that? What's going on? Like something just changed over there. Now, as mammals, we are programmed that when we experience threat, we will automatically change our facial tone and change our voice in order to signal for support. And so adults do this naturally too, but kids do it very, very naturally, where their tone of voice will change and it'll get your attention, so you will go and support them. That's a wired in thing for all mammals. Your cats and dogs do it as well. And have you ever, let's say, had a friend, an adult friend that you talk to on the phone frequently, and they call you up and pick up the phone and they don't get 2 words out of their mouth and you're like, what's wrong? Because something in their voice is signaling to you that they need more support. Or have you seen that friend walk into someplace and you just see the look on their face and you're like, oh my God, there's something going on. Again, this is how we're wired as humans. So we have a threat. We immediately signal for social support by changing our facial tone, by changing our voice pitch or tonation, those sorts of things. Now, if support doesn't come, then we immediately then go into what we call the mobilization system. This is the fight or flight system. So a little example I like to use is, imagine you're going out for a run someday in a unfamiliar territory. So you're visiting your friends or your parents or something, go out for a run, and you're running past a yard and an aggressive dog comes running out at you. And you might start off by going, oh my God, nice dog, ooh, nice dog. Okay, so you're trying that social engagement session. That doesn't work. Dog keeps coming. And then you're like, oh, You huff it, right? Now the mobilization system is in gear. Your blood pressure is up, your heart's pumping. You're like, oh my God, gotta get away. You get over a fence. Let's say you get away from the dog, and you're safe. You get into a car, you get over a fence, dog can't get you. The mobilization system worked. That fight or flight got you away from the threat into safety. So it worked to get you into safety. So let's say once you get to safety, you call up your friends. You're like, oh my God, you won't believe just happened. I just got chased by a dog. I just got away. And then after you debrief it with your friend through your social engagement system, a week later, you're kind of chuckling about it, maybe, or 2 weeks later. It might take you a little longer than a couple of weeks to chuckle about it, but eventually you'd be like, oh my God, yeah, that was, you can remember it, but there's no charge internally around it because your nervous system has gone back to normal. Okay, so what if the mobilization system doesn't work? What if it doesn't work? Well, there's some studies that have been done over time. One was a guy by the name of Dr. Livingston. He wrote a kind of a famous book in the early 1900s. Dr. Livingston was on safari in Africa and he got mauled by a lion. And so as soon as he, the lion popped out, he went into fight or flight, the lion caught him, and then the lion's kind of shaking him around. And he had a very descriptive experience of how he went out of his body, had an out-of-body experience, and he's watching himself be mauled and shook by this lion. And he wasn't experiencing any pain either. And it was almost like he wasn't in his body anymore. Obviously, he survived the attack because he went on to write about it. And of course, when he was coming back into his body, then he started to feel different things, but he was left in kind of a state of dysregulation for a very long period of time afterwards. So how do you explain that? Well, the final mercy of the nervous system is when we go to what we call the dorsal-vagal complex, and the body shuts itself down. If we've tried to socially engage and that doesn't work, or we've tried to mobilize and that doesn't work, the very last thing that happens is the nervous system shuts completely down. There's also, if you've ever watched like the National Geographic, and there's once in a while I can find a video of a cheetah or something dragging a gazelle back into their tree or their bush or their lair or their cave or whatever it is. And they have a camera in there, and the cheetah drops the gazelle off and then goes back out to hunt. And after about 10 minutes, the gazelle kind of like gets up and like shakes for about 10 minutes and then it runs off. Well, that was a gazelle essentially in what we call dorsal vagal shutdown. We say playing dead, like a possum plays dead. The possum's not actually kind of playing dead. They actually are kind of dead. Their heart rate is slowed down so much. Their breathing has slowed down so much. They've evacuated their organ systems, have evacuated energy. Their bowel systems have evacuated, bladders have evacuated. So it actually kind of looks like they're dead. And again, that's the last response because most predators don't want to eat something that's already dead. So it's kind of like a last ditch effort for survival. And so these are the 3 levels of safety for all mammals. Now, what happens if we actually do survive? If our life continues on after someone has been in that deep shutdown state. So some people call this the freeze state. Freeze state and shutdown state are a little bit differently. We could use them synonymously for now, but there's some differences between them. We talk a lot more about in our training programs. But for now, you can kind of maybe think about fight, flight, and freeze potentially. You could plug that in there if you wanted to, just to help support your understanding of it. Now, if we do survive that state, what happens is very often we get caught or stuck in this loop of chronic autonomic nervous system dysregulation, where a person now really is stuck and caught in a threat loop. And the threat loop is they're primarily trapped between the shutdown and the mobilization system, and social engagement is very, very difficult for folks who experience this type of autonomic nervous system dysregulation. So it's very difficult for people to maintain eye contact, very difficult for people to trust someone else, to let people support them in a deeply way. They're really shut off oftentimes from deep vulnerability for all kinds of great reasons because of the experience and what's happening in their nervous system itself. So there ends up being this looping primarily between mobilization and shutdown, anxiety and depression, fight or flight and chronic fatigue, back and forth, back and forth, and back and forth. And the social engagement system never really is able to fully kind of remediate everything that's going on. And so this is, hopefully this little kind of model here is helpful for people to understand how someone can end up in a chronic dysregulated state, even on small little levels. And people are always, when they have this kind of experience, kind of always prone, if you will, to having even small re-traumatizations or working in certain parts of the body that are associated with the original trauma can reactivate these old trauma loops in a more profound way. So the definition we kind of get to here, gang, is that what is trauma actually? Trauma is an incomplete survival-based response causing chronic dysregulation of the autonomic nervous system. So if we go back to what we were talking about, one of the very first slides, like what is trauma and trauma defining and who has trauma and who doesn't have trauma, I always look at it from not what the story says, but what does the nervous system say? The nervous system won't lie about whether or not someone has experienced trauma or not. I'm not saying someone lies when they have a narrative, but it's much more difficult to kind of judge someone's narrative or try to consider someone's narrative, whether it's accurate or not, if we consider their nervous system. Because if their nervous system is in a chronic dysregulated state, it's pretty clear that there's something that has precipitated that dysregulated state. And very often, that is a trauma or a series of traumas that occurred in a previous time in someone's life. Hopefully that helps to close loop on that, folks. So what can we do about it? What can we do about it? Well, one of the things there's a lot we can do. Kind of one of the first layers that we can do as massage therapy professionals is to make sure that we are setting up our practices in what we call trauma-informed ways. So here are the 5 trauma-informed principles: safety, trustworthiness, choice, collaboration, and empowerment. And so all of these principles can be automatically baked into your practices. How you work with your clients in the world can be baked in here. So the very first principle is safety. We're ensuring physical, emotional, and psychological safety for every one of our clients. So we ensure physical safety. Sure, a lot of you are really good at that. You make sure that your tables are adjusted well, that they're safe, that the legs are strong, they're not going to buckle. Make sure there's no trip hazards in the area, right? Make sure that the heating table is not on too hot, so they're not going to get burned. Like all those kinds of things ensure physical safety. How often are we ensuring emotional safety for people? Well, how can we do those kinds of things? Well, you can think about and psychological safety. Well, what kind of conversations do you have with your clients about like even the room? Do they prefer to have the door open, cracked open a bit, closed, locked, not locked? I mean, in a lot of states, we have regulations we have to follow around what we do with doors, but do we ever give people a choice around that? Like just someone having a choice can create more emotional, psychological safety for somebody. So there's all kinds of things we can start to do to really help people create safety. Think about exits too. Are exits easily accessible for people? I always want to make sure that I'm never really standing too long between someone and an exit. And you might think, well, why does that matter? Our subconscious mind is always running, and even on the table, oftentimes, if someone has a trauma history, they're part of their subconscious mind has a radar on to make sure that they can get out of the room if they have to, without even consciously realizing it. And so just kind of blocking an exit for too long can ramp up someone's trauma response, even their heart rate, their blood pressure, those kinds of things can change. Our restrooms friendly for all genders? I mean, things like that have to do, again, with how we just create safety for people. So there's a whole list of things that we talk about in some of our trainings as we go through these things. All right, so trustworthiness. Really kind of like the basis of trustworthiness is ensuring these clear expectations, consistent boundaries with compassion for folks. Our treatment goals clear when you're working with a client? Are what you're going to do with the patient clear? Have you cleared ahead of time? Okay, so we're going to do some deep tissue, which means we're going to do this. We're going to do some light work, which means we're going to do this. The little phrase I like about thinking about trustworthiness, how we build trust isn't always about liking what's going to happen, but it is about always knowing what's going to happen next. Not always about liking what's going to happen, but it is always about knowing what's going to happen. So the little analogy I use is if you went to your doctor for, let's say, like a flu shot or something, and so you knew you were going to get your flu shot, and your doctor kind of disappeared behind a curtain, and then all of a sudden he just jumps out and jabs you with it. You're like, ah! You're surprised, and oh my God. Like, are you going to trust that doctor again? Well, probably not, right? Because you didn't know when it was going to happen. Compared to if he said, okay, here we go, we got the shots, a little needle, and a tap on this little pinch. Like, that's why they do that, because they're basically saying, listen, no one likes to get a shot, but this is how it's going to happen, how it's going to go down, so you know what's going to happen. That's how you build trustworthiness with people. So with your clients, how often do you engage in that kind of conversation, especially if the treatment may potentially be somewhat unpleasant? With neuromuscular trigger point work, deep fascial work, sometimes those things, they're not super pleasant for people. So how well are we prepping or letting people know that's what their experience might be, and setting up ahead of time communication guidelines, clear communication guidelines around that. So that's just one kind of example of how you can start to build trustworthiness into your process in your program. Well, so choice is really a big one. Choice is kind of at the middle of this list. If you think about it, people who've had traumatic experiences, lots of times what they were robbed of was choice. That's what was taken from them. That actually was really a precipitator of their trauma in general. So how much choice does your client have over what kind of treatments you're going to do with them? What kind of choice do they have over the scents in the room? What the lighting is like? What kind of music you're playing, the sound, what kind of draping that you do with them? How much clear choice do they have around that? Before touching clients, do you ask permission before touching people? And this might sound a little awkward because you're like, well, they're there for a massage, so obviously they're okay with me touching. Worked with a lot of people who've experienced trauma who actually weren't good. They came to massage because someone told them it was going to be good for them, and they were really reticent about it. And so I had to be very clear about asking permission to touch, like as I went from body area to body area, clearly getting consent to go throughout the body. I'm not saying it always has to be like that with every client, but if we want to create trauma-informed principles in the work that we're doing, these are things you want to keep in mind constantly of how often are we getting clear permission and clear consent for someone to work directly in their bodies. And if someone says, I don't want you to work there, are there negative consequences for their choices? And are those negative consequences clear, or are they arbitrary? Like, is the person afraid we're going to be upset if they say, I don't want to work in that area? And then what does that mean? So there's all kinds of interpersonal dynamics that can occur around choice. So how clear are we that the choice is for them, and that it doesn't have anything to do with how we feel about how we can help them or those sorts of things? All right, so then we move on to collaboration. If you haven't noticed, like these phases, safety, trustworthiness, choice, collaboration, they're actually kind of in a hierarchy, aren't they? Because you actually can't have choice, real true choice, without having trustworthiness. And you can't really build trustworthiness without having safety. So we kind of go right up through a hierarchy of principles here. So what about collaboration? Well, we're really about this is a client sharing experience, really a working together. How often are you working with your clients to help them achieve their goals? Or are we dictating or telling the client what's best for them without it being a kind of a power sharing? Are we giving the client's preference, or are we giving their experience and what they want substantial weight in the collaboration? Are we letting them know, okay, so this is what I think might work best for you. This is where the positives are. This is where the drawbacks are. What do you think about that? What's your experience tell you? So how kind of are we working with people in this collaborative sense? And you can set up systems to do this with every single client you're working with, whether they've experienced trauma in a profound way or not. Again, most likely 90% of people have experienced some type of traumatic event. Most likely 90% or maybe more of your clients have a physiology or nervous system that has experienced some type of substantial trauma in their past. So these principles just make a lot of sense to use. Okay, and then finally, empowerment. So how are clients' strengths and capabilities recognized? How are we empowering what they're doing? One of the most important things I've realized is that even when someone feels out of sorts, even when they feel like they're having more discomfort after the body work, having to understand that, wow, okay, so what's happening in your nervous system? Your nervous system must be trying to do something in order to balance out the work that we've done. Doesn't mean anybody that has done anything wrong at all or anything right at all. It just means the nervous system got input, and the nervous system is always doing the best it can to sort through the input it's getting to help us to create a state of homeostasis. That's really what the nervous system is doing. So I really like to kind of feed back to people as much as I can. Hey, your nervous system is always doing the absolute best that it can do for you in the conditions where you're experiencing right now. How can we help your nervous system to get to a better place? So that's just a way we're empowering what the person is already experiencing, especially if they're experiencing something potentially distressing for them. That's a great way to go through this. How are we moving towards higher levels of skill and function for people with the work that we're doing? Are we providing relief and support? And are we building capabilities on the part of the client to help them be able to move further forward? So these are the 5 trauma-informed principles. And the more you learn about these and you think about what I would think about after tonight is, or right now even, is, what is 1 or 2 things I can do in every one of these domains? Maybe start off by thinking of what are 1 or 2 things I'm already doing in each of these domains, but am I doing them on a regular basis? Am I doing them consciously, or am I doing them unconsciously? Am I doing them all the time? Or I'm only doing them once in a while with certain people? How well can we create frameworks around this in order to create trauma-informed practices? Now, I know for sure that if I would have had some of these things set up ahead of time with that treatment with Shelley that I was doing, it's a high likelihood she would not have become so dysregulated and re-traumatized by our time together. So the trauma-informed principles are really like the first step to create a safe environment, safe and supportive environment for your clients to get the most out of their treatments together. Now, the second level is what we call trauma-sensitive care, which we don't have time to talk about tonight. But trauma-sensitive work is really about, well, what happens when they do experience dysregulation? When they do experience re-traumatization, what do we do then? That's when we have to start employing what we call trauma-sensitive principles. And these take a little bit longer to kind of work with. Okay, so we talked about the 5 trauma-informed principles. So there's some things to consider here, gang. This is what you might want to consider. Is your client intake trauma aware? When you have your client intake and you have people answering questions, you have questions on there that might kind of be considerate of someone who's experienced trauma. So what are some questions you could ask on your intake? Well, you might ask one like, hey, have you had any negative or unsettling experiences with massage in the past? Might just be a basic question. And what, if anything, would help this massage feel the most supportive for you? Like, those are things you could put in your client intake to start to kind of weed through understanding where someone's operating from. Another really good question to ask on your intake is, are there any body areas or massage techniques that you would like your therapist to avoid? Again, this is just giving people a sense of choice, a sense of agency, a sense of understanding ahead of time to know that their preferences will be considered once you start moving into the treatment planning or the treatment process, if you will. All right, so is your client intake trauma aware? Can you recognize the subtle signs of trauma reactivation? Do you recognize when someone's becoming unsettled, when they have shifts in their breathing, when there's emotional shifts or changes, when the person has difficulty making eye contact with you, when someone seems disoriented or dissociated? There's all these little subtle signs of trauma reactivation that if you can catch them early, you can help kind of guide a person to stabilization. So these are really important things to learn and consider moving forward. Do you have a way to consistently respond when a client's nervous system becomes dysregulated? Again, this kind of is more into that trauma-sensitive kind of framework or trauma-sensitive care. These are just questions to consider. I would take these afterwards, and where can you kind of think about learning more about these things to create more trauma aware, informed, and sensitive environments. And do you apply the trauma-informed principles with everyone, which we talked a little bit about on that previous slide. Okay, so these are just things to kind of think about and consider as we kind of start gliding into our Q&A phase right now. I know you'll be getting a copy of this PDF afterwards in the next day or so. I know you're going to get a copy of this. In that PDF, and you can scan it right now if you want to, but you get a link if you want to get a lot of free resources at the Somatic Coaching Academy library. We've got a podcast in there. We've got a lot of video support in there talking about these topics: trauma-informed, trauma-sensitive care. It's a free way to access a ton of material at the Somatic Coaching Academy. And so, but this will come to you tomorrow as well, and or later this week as well. And we'd love to have you visit us there and ask us any questions and get just a lot more support in learning more about trauma-informed and trauma-sensitive care and trauma-sensitive practices. All right, so I'm going to pop out of that share and come back to here. And
we did have one chat come in.
yeah,
and everyone, there is time for more questions and comments. If you suspect that a client is showing signs of having experienced trauma, but they haven't brought up this topic, do you ever broach this?
That's a great question. So there's, with the different levels of trauma care, we have what we call the trauma-informed level. And so after this training tonight, you're all trauma, consider yourself all trauma-informed. You understand about the trauma prevalence spectrum. You understand, oh my God, 70% of people are probably lost in this middle, 20% of PTSD, 90% had, traumatic stress. That's all trauma and aware. Consider yourself introduced to trauma-informed care. So again, you apply that to everybody at all. And by the way, you notice we're not even talking yet at all about the specific history that someone would consider traumatic at this point, right? Trauma-sensitive care goes a little deeper. And trauma-sensitive care, again, we're working specifically with someone's nervous system. Deeper than that is what we call trauma-specific care. So trauma-specific care is where you're working directly with trauma content. Now, that level of care is reserved for people, for psychotherapists, for social work, for trauma coaches who have a lot of training specifically helping people to navigate trauma content. So if we back up a notch, trauma-sensitive care, if I'm working with someone who begins to be showed signs of dysregulation and likely has a trauma history, I can even ask them, have you experienced, some unsettling things? You have a trauma history? And if they said yes, I don't need to know any more about the trauma content in order to help them stabilize their nervous system. So I don't delve into that trauma content. I stay right with, let's help the person's nervous system get stabilized and then refer to someone who's trained in helping people delve deeper into trauma-specific content if necessary. Now, I will say there's been a lot of research coming out lately, the importance of regulating people's nervous system is just as effective, if in lots of cases, as actually revisiting trauma content. What's been shown in the past is people who revisit a lot of trauma content don't necessarily end up with more regulated nervous systems. But people who spend a lot of time with trauma-sensitive work with regulating the nervous system actually end up having better outcomes than people who continue to revisit trauma content. So I'm not saying visiting and working through trauma content isn't important, but we also want to put it in a balance where it has to be. That's why I'm so excited about the work that we do. So the long answer to your question is we really focus on the nervous system regulation part. We don't have to get into a person's trauma history in order to do that.
All right. This is fabulous presentation. And then Andre is asking, how do you recommend aligning with psychotherapists for referral resources?
Yeah, so I think having a conversation with the psychotherapist is really important. And I think it's also important that as a body worker, as a rehab professional, that we actually have the tools already in order to help the psychotherapist feel supported with what they're doing. So The psychotherapist doesn't want like us to have to lean on them to educate us to help their clients. If we go to the psychotherapist and we say, listen, I've got training in trauma-aware, trauma-informed, trauma-sensitive care, I would love to be able to help you get better outcomes with your clients. Then that's a great way to pair and partner with psychotherapists. That its onus is on us to get trained up and to really understand as much as we can how trauma impacts and affects the body. And then so we can partner with psychotherapists. When we've done that, we get a lot of referrals from psychotherapists and mental health professionals, because we know that they know that we understand where they're coming from and the powerful work that they're doing. I mean, we're helping them get better outcomes. That's the whole point.
And helping the client, most
Yes.
of all.
Yeah.
Another thank you. The program is really good. Daniel is asking, you mentioned that there were things we discussed here that you feel would have avoided your situation with Shelley. What specifically would you have implemented regarding that scenario in hindsight that you would have done differently?
Yeah. So for me, even though I kind of knew Shelley in a social sense, and I had seen her before. If I would have had a trauma-aware intake, if I would have asked certain questions in there about how are you doing, what's your history around regulating your nervous system been over the last 6 months or over the last year? How often have you felt dissociated? She actually had some experiences like a couple of weeks before in hindsight that I didn't know about, that she thought massage would help her stabilize. So she came in with some assumptions of what massage and bodywork could help her do. And I wasn't aware of what her history was even getting up to that point. So I think for me, just having that trauma-aware intake and asking specific questions around how have you been over the last couple of months? Have you had any experiences where you felt really unsettled, emotionally dysregulated, those types of things? I think we had a little cue on coming in to understand what the signs would have been then that she exhibited when we were doing work together on the table. So I think that's like probably the number one thing I would have done. And it would have all based itself in that trauma-informed kind of care model.
Before I read Jessica's comment, I mean, as a therapist, you have someone walk in the room and they could have just spilled a gallon of milk in the back seat of their car on top of their cell phone. So they're coming in and they're, how are you today? And they're like, like this. How do you distinguish between, something larger than just a reaction to an unfortunate event in the back of the car, let's say?
Yeah, so it's a great question, Danielle. So partly what I'd be asking about is not just what happened like just now. I'd say, is this a pattern for you? So like this, what just happened with the car, your nervous system, you really seem like you're really wound up. Like how often does that happen? How often you get wound up about stuff that happens? And then how long does it take that winding up to resolve itself? Like that's a question I would ask. I'd ask about it in terms of a pattern, not just the isolated incident, but how many times has this happened before? And how often does it take you to kind of seem like you re-regulate again? Those answers to those questions would again cue for me, because if it's something that happens very often and it's something that lasts a long time for somebody, then that would click to me that there's an issue with the nervous system activation and then kind of reorganization kind of flow.
Okay, interesting. And now Jessica is asking, can you please talk about top-line response items for a patient who is in a state of autonomic nervous system dysregulation? If we miss these original signs for any reason, is the first aid you had provided holding space, what would you recommend? I realize we aren't going through the full trauma-sensitive work curriculum here. But did that make sense to you, Brian?
Yeah, I'll try to answer as quickly as, as kind of briefly as I can, because it's kind of a big topic, and it's really comes down to understand, well, I guess two things. So we talk about with working with trauma and being with trauma. And so being with trauma is kind of like, how are we, the professional, being with trauma? Oftentimes, when someone else is experiencing a trauma reaction, it can facilitate our own stuff can come up. And so a lot of it is about us being able to do our own work to hold space, not only for the client, but for ourselves, in order to kind of create an environment that feels more stabilizing for someone. So part one is, how much of our own work are we doing? And do we know our own, what we call stabilization anchors? So we talk a lot about creating stabilization anchors with our clients and with ourselves in the training programs that we do. So if I know, if I do a really good trauma aware intake with somebody, and I know that someone has some type of trauma history, what I will do before we do work together is we'll actually identify some trauma anchors for people. This is another thing, if I would have known with Shelly ahead of time, I would have done, so that when she experienced dysregulation, we would have known what trauma anchors to go to. Because the worst situation we can end up in, even if we're really skilled in this area, is to have someone experience dysregulation or dissociation and be completely blindsided by as a professional and not have established grounding anchors with the client ahead of time. Like that's very difficult for any of us to manage, because I could say take some deep breaths, but what about deep breath? What if there's something about breathing for someone that's actually traumatizing? Now I'm making all kinds of assumptions what might be good for the person that can create all kinds of problems for them. So a lot of times, like, once the toothpaste is out of the tube, it's kind of too late, and we do the best we can to hold space, help someone kind of ride it out, and then debrief afterwards. But that is a very, I never want you to be in that position. Let me just say that. I never want you ever to be in that position. So, which is why I'm trying to do more of these kind of more of the information out here, is like, get your training up early so that you're never in that place, so that you know what someone's anchors are if they do get dysregulated, so that you can go right to those go-tos with somebody when you need to.
Oh, very good. And I don't see any other chats have come in. We still have a minute or two. But what I would like to mention is that tomorrow you'll receive a follow-up email. And in the email, we'll include the recording of Brian's presentation tonight. It will include a copy of his PowerPoint presentation and his contact information, so that you can continue the conversation with Brian. I originally met Brian at AMTA National last year. And I know you're not attending this year, but are you out and about at any shows?
Not that I can think of at the moment in terms of conferences, speaking at conferences and those types of things.
Yes.
Yeah, I don't have any association conferences planned at the moment. We've got a lot of trainings, though, we're doing at the Somatic Coaching Academy for over the next couple of weeks and months. So a lot of those kinds of things. We do a lot of kind of demonstrations of our techniques, like to the public through the Somatic Coaching Academy. So we're doing a lot of work in that way, for sure.
Okay, so but you won't be traveling around the country this year. Doesn't not yet.
Yeah, not for these things. I'm doing a lot of traveling, but a lot of it has to do with like some organizations that we work with and private training programs that I do for companies. Yep.
Okay, great. Well, I haven't seen any additional chats or questions or comments come in. Again, watch for the follow-up tomorrow, the follow-up email. If you don't see it in your in-basket by tomorrow afternoon, I would check spam or junk folder. And if it's not there either, please feel free to email me as well. And thank you all for joining. Please join us again. We have a great August ahead of us. On August 6th, James Weslowski will be presenting an EduTalk on quick manual therapy techniques for musculoskeletal pain relief. And for those of you not familiar with the EduTalk Diabetes series, Dale Alexander will be presenting on August 13th, an evolutionary perspective on diabetes, how body work may assist. And then we close the month of August on August 20th with Tanya Rodriguez, implicit bias training, working with diverse populations. So some good EduTalks coming up. We've got over 4 years of EduTalks in the archived library on biotone.com under the EduTalk tab. So please check out talks you may have missed and join us going forward. Brian, thank you so much for your presentation tonight. Very thought-provoking. I've often joked that birth was a trauma experience for everyone. So we're all walking around with something. And I think it's a great suggestion about the intake form. And, I think the intuition too, you can sense, how your client feels almost sometimes when they walk in the room. And I know I've been the client. So I've had that experience myself. Thank you, everyone. And thank you for the work you do for the massage profession and your clients. Take care. Join us again. And we'll see you next time. Bye-bye.
Bye-bye.